Okay, so welcome to Eat, Move, Think, the show about optimal wellness brought to you by Medcan.
Wow. Do it again.
Oh, I was practicing. Okay, ready?
Welcome
to Eat, Move, Think,
the show about
optimal
wellness brought to you by Medcan.
Yeah, this is extremely good. Thank you.
Well, my grandfather on my mother's side had prostate cancer when I was a teenager. To my knowledge, it's not what killed him. Like many men, he died with it, but it didn't die of it. Other than that, I hadn't really had much exposure to prostate cancer. But once you have it, all of a sudden you realize that a lot of people have it. It is very, very prevalent out there with men.
Once you have it, you realize that a lot of people have it.
Prostate cancer is the most common cancer among men in Canada.
So, 76 Canadian men will be diagnosed with prostate cancer every day. That's a pretty incredible stat.
Yeah, that's an estimate for this year, actually. And so when you think about it, a lot of people probably feel like this man did that we just heard from.
Yeah, it's not something you think about until you really have to start thinking about it, until you're forced. So prevention is key, is the point.
Yes, totally. And once you look around, you see how many other men have probably gone through something similar that you have. It's very prevalent, and it's all about prevention, because a lot of the time your diagnosis has nothing to do with how you feel. And the sign that you need to start doing something about it comes from a test, comes from a screening.
So get checked.
So we just heard the voice of a Medcan client who was so kind to share his journey with us for this episode. He was diagnosed with prostate cancer not too long ago. He was actually in the middle of a board meeting when he first got the call from a Medcan doctor that there was something that didn't look quite right and that he should come in for future testing. And he's a prime example of why the ultimate prevention is to get screened.
Wow. Board meeting to remember, I'm sure. I'm Chris Shulgin.
I'm Jasmine Ratch. We're the producers of Eat, Move, Think.
The point of this episode is prostate cancer prevention, prostate cancer early intervention, and the fact, as our guest indicated, it is profoundly possible to live for decades and decades with prostate cancer and have it not have anything to do with what you died.
And this episode is unique as well because we don't just give you the clinician's perspective, which is so useful. We give you the patient's journey. What does it feel like to be diagnosed with prostate cancer? What does it feel like to go to see your doctor and hear what your treatment options are? And then what is it like to go through those treatments? We have 2 Medcan clients here to share their stories. And then we have Chief Medical Officer Dr. Peter Nord and our Director of Urology, Dr. Rajiv Singal, to sort of tease out the implications of these experiences that the men had and what you should know about both the clinician's perspective and the patient's perspective of how you can best ensure that if you are at risk of prostate cancer, that you get screened regularly, you know exactly what to do. And if, worst case scenario, you are diagnosed with prostate cancer, there are so many options for you to choose from.
Amazing. Okay, let's get to it. Here's Dr. Peter Nord.
So Rajiv.
Hey, how are you?
How are you doing today?
I'm good. How are you?
Good. Thanks for taking the time today.
My pleasure. It's always good to speak with you and talk about the honor of looking after our patients.
So today we're talking about prostate cancer. It's pretty common just in general, obviously way more common in men than women because, of course, women don't have a prostate gland. Other than that, it's very common. I remember I'm going through a med school. I can remember a professor once telling me for men in their 60s, there's a 60% chance that they've got prostate cancer, 70. Once you get in your 80s, there's an 80% chance of having prostate cancer, but you may have it, but it may not kill you. So is that changed at all over the last number of years?
That's actually a good rule of thumb. It's a nice way to, just to illustrate to patients that, this is a very common thing. And truth be known, Peter, I actually used that line today with somebody when I gave them the news about their own particular diagnosis, right? And I was framing it in that way, right? The background is, basically 10% per decade if we have the ability to go looking hard enough. And, and our job is to not necessarily find those men, but to find the subset of men that will have, as I like to say, not incidental disease, but consequential disease.
I remember I had a patient years ago in my family practice, And not only could he shoot his age in golf, so he was 80 years old and he was shooting 80 on the golf course, but if you saw his x-rays, they were just looked like somebody got him with a shotgun. His bones were littered with prostate metastases and not a lot of pain. We had a little bit of pain medication, and he was having a really high quality of life. And it was just really dramatic that somebody would have, what you would think of as sort of end stage type prostate cancer, and yet was golfing his age.
Yeah, no, I mean, you're right? So even with advanced incurable disease, there's a subset of folks that can do well, right? And then that becomes how we would counsel them and effectively try and make decisions on how to treat, incorporating goals of care and what they want to do. Ideally, even that individual I would submit with advanced disease, there's therapy behind that, right? And therapy has potentially some consequences. And if you could reverse engineer that clinical scenario a decade before, could you find that individual and intervene at a point where he wouldn't just be having disease that's controlled, albeit with a high quality of life, but potentially cured? And, recognizing that we all have to go at some point from something.
Yeah. Well, how about if we backed up 4 decades? So when we talk about screening and prevention, which is obviously a big focus for Medcan, what do you think about that? Like, what's changed over the last number of years in terms of prevention and screening? And I think people know, they've heard PSA, but they may not know really what a PSA is. And so maybe dive into a little bit about, what is PSA and what is the screening protocols so we can identify people early?
Yeah, no, thanks for that. So maybe the starting point, I always see screening and detection in the context of sort of a larger men's health initiative, right? And as we get older, and I've said this to anybody who will listen to me, our female counterparts tend to do a better job of advocating for their health, seeking out attention for a whole variety of things, right? Men tend to be silent, right? And so whether it's related to getting your lipid levels checked, whether it's related to navigating prostate cancer risk, whether it's related to mitigating risky behavior, whatever that may look like, we don't do as well in general compared to our female counterparts and our female partners. And so I think you can't be silent, right, until things advance. So I do think people tend to be more proactive. Certainly the Medcan population are very much attuned and want to live well and live long.
Dr. Singal is right. In fact, now seems like a great time to hear from some Medcan clients themselves.
Hi, I'm Michael. I am 70 years old, happily retired for 5 years, spent my career as a corporate securities lawyer on Bay Street. Had what I consider a good career, but I'm happy to be doing something else right now. Until Medcan, I'd never had an annual physical in my life, and I guess I probably started at maybe 50-ish.
And here's our second client, who we heard from at the top of this episode.
I am 61 years old. I'm the father of 2 teenage girls, been happily married for 20 years and counting, and I'm a senior executive at a public company. It was 2 years ago, so we were doing a board meeting, a virtual board meeting. It was April of 2022. I'd done my annual physical that summer at Medcan, and my doctor at Medcan, Dr. Wartzman, said, I want to monitor your PSAs because it looks as if they've gone up, and you're inside the range, because the range for a man of your age, I was 58.7 at that time, is below 3.5. I'm literally in a board meeting and I get a phone call from Medcan. So I go off camera and mute, and I was able to get the doctor at Medcan on the phone, and I asked him what's going on. And he said, you're up to 3.3 and I just don't like the trend. And I want you to see your urologist.
So this concept of PSA, which is a blood test, it stands for prostate specific antigen. It's a normal part of physiology. So prostates make PSA. It has a role in fertility. That's sort of the role that nature provided for it, but we use it as a biomarker. And so what we're basically doing in the blood is we're measuring how much of this protein leaks into the bloodstream. And the higher the value, the more we get concerned. But lots of things can make it leak, right? So which is basically a disruption of the normal anatomy of the prostate. And the idea is that cells are not as healthy and things will leak more with cancer. And that's why you get elevated results. But it's also true that a benign process, which is simply the prostate growing, will produce a certain amount of PSA. And what might be normal for you, Peter, as a PSA value may be actually abnormal for somebody who actually has a tiny prostate.
And actually, a man's PSA levels might remain low, even if he does have prostate cancer. This was Michael's situation.
Part of the blood work was to look for PSA levels, but mine were never elevated. In fact, at no point in the process would PSA have ever suggested that I had prostate cancer. Part of the physical, there was a rectal exam, and in 2010, the doctor at the time said, something doesn't feel quite right. We'd like to send you to a specialist. I was referred to Dr. Singal, who is a senior specialist, one of the best.
So there's a little bit of nuance that comes with that, but the starting point so we can help tease things apart for our patients is you start with that information with the PSA. And so we tend to use a multi-factor risk assessment profile. What is the PSA? Has it changed over time? Is there a family history? You add ethnicity potentially. As a general rule, Black men have a higher risk than white Caucasians relative to Asians, and what the physical exam looks like. You could put things together and give our patients, our clients, a reasonable estimate of this is what you have. This is your chance of having prostate cancer. This is my sense of what your chances of having real prostate cancer. It becomes this thing of, if we knew you had that, we would act on it. But are you prepared to live with a diagnosis of cancer is if what I find is incidental, right? Just what you alluded to at the beginning. The added piece in the last few years that has, I think, changed the paradigm quite a bit is the advent and the availability of prostate MRI. We started to use it in the scenario of surveillance for low-risk patients to see if there was anything that we were just missing that we hadn't defined fully. Because there's enough evidence that may move the needle from, yes, you have prostate cancer to, well, actually, yes, you likely have real prostate cancer. And so I increasingly, lean towards that, Peter, particularly in the last couple of years.
An MRI made all the difference in this Medcan client's diagnosis.
I immediately panicked, but then took it on. I didn't duck it or put my head in the sand. I scheduled an appointment with Dr. Singal, as recommended by Dr. Wartzman, who called Dr. Singal a quiet rock star, by the way. And I would say Dr. Wartzman is also a quiet rock star. These two gentlemen I have the utmost regard for their capabilities and their style. So I went to see Dr. Singal in July for a physical exam. There was nothing notable, but he said at the time, I probably could get you in for an MRI. Do you want to do that? And he said, or we could just monitor it. My dad died of lung cancer when I was 17. Of course, this isn't lung cancer, but I didn't want to fiddle around with this. So I said, absolutely.
One of the tests that we're using at Medcan is the PSA ratio as another way to further dig in. Because I think you've identified the $64,000 question is it cancer or is it real cancer? You said that a couple of times. So how do we determine that? What kind of tests lead you to believe that, okay, this is worrisome, this isn't?
So the PSA ratio, which just basically subdivides sort of the good PSA from the bad PSA, right? There's a proportion of PSA that is more associated with cancer than not. So all we're doing is measuring the ratio of the two. But to ultimately tease out real prostate cancer from incidental prostate cancer, you need to do a biopsy.
Now let's hear from Michael on what the biopsy experience was like from a client's perspective.
They usually, I think, take 12 little samples from different places in your prostate. So I think they miscounted because they did 13 in my case, of which one came back cancerous. And the recommendation basically was active surveillance, which essentially means there's no need to do anything yet because typically prostate cancer is very slow growing. And basically after a year, another biopsy. And unfortunately, the result of that biopsy was 4 out of the 12 samples were cancerous. So clearly it was growing and growing much faster than would be comfortable. I had one other question, which is, if I just ignore it, how long do I have? And the answer came back, you probably have 15 years, but you won't like the last 5. I was 58 at the time. 15 years seemed like a reasonable amount of time, but not quite enough. I had no symptoms. I felt no different, leading up to the initial diagnosis. I felt no different throughout the piece. As I say, my PSA levels never really went up. If it hadn't been for the physical exams leading to a further testing, I would never have known I had cancer.
If it was simply like getting an x-ray, it wouldn't be a big deal, right? So, but it is a minor procedure that most men tolerate without difficulty, but there are some risks. There's some bleeding risks. There's some, a very small, but non-zero, not nominal risk of developing significant fever and even occasionally true sepsis from a biopsy, right? So you only know when you have the biopsy information, but you just have to be thoughtful on getting to that point of recommending, yes, you should have a biopsy based on that.
So done the biopsy, negative, that's easy. Positive comes back. So maybe we can talk a little bit about the grading system. And people may have heard about a Gleason score, and there's a TNM, a staging that goes on as well. And I think it's sort of changed over the years. So maybe you could clarify that. But that's an area that some of my patients have some confusion around.
So we talk about grade and stage, right? And that's true for any cancer, whether it's prostate cancer, bladder cancer, lung cancer, pancreas cancer. And so grade is what really drives the decision. So the Gleason score, so if you're told you have a diagnosis of prostate cancer, the next question is exactly what we were talking about earlier. Is this incidental or consequential? So the Gleason score is the most reliable and powerful tool that we would use to define it. It's a scale out of 10. And what we're actually doing is measuring 2 subtypes. And we give them a score from 1 to 5. And so the sum is the Gleason score. And that's why there's a little bit of confusion, right? Because effectively the starting point is a Gleason score of 6. And so patients will say, well, 6 seems awfully high. What about 1 through 5, right? There is another way that we try and frame it now in terms of broader groupings, but effectively Gleason score of 6, which is a sum of the 2 3+3 patterns, is low risk, not necessarily incidental, but the vast majority of those patients with active follow-up with their clinicians can be followed. And I'd say the vast majority of those men never need to be treated. A small minority won't, but they need ongoing follow-up testing, repeated biopsies, and the like. And then so Gleason 7 basically introduces a little bit of pattern 4, right? So to go from 6 to 7, which seems like a jump of 1 number, what it really reflects is you're now introducing Gleason patterns of 4 or Gleason patterns of 5. And that's why 7s behave quite differently. And in fact, we divide 7s as to whether there's more of 4 plus 3, or whether there's more of 3 or 3 plus 4. But Gleason 7 prostate cancer is what I would call intermediate risk prostate cancer, where the conversation starts to turn towards that probably should be treated if you're otherwise healthy enough and your life expectation is to live at least 12 to 15 years or beyond, then you should look after that. And then the high-risk cancers, where there really is a worry and where you would do testing that includes, has it already spread before introducing therapeutic options, are the 8s and the 9s and the 10s. So that's the broad category. What you alluded to with the TNM system is staging, right? So in general, if something is confined, it's stage 1. If it's nearby, it's 2. If it's regional, it's 3. If it's widespread, it's 4. But the TNM system refers to the actual pathological information you get when you can fully stage somebody. So a lot of it can't be truly with prostate cancer teased out unless you actually remove the prostate, which is only one of the treatment options, which we will get to, where you would then have the whole organ and then you can measure it. And so the T refers to tumor. It can go from T1, T2, T3, and it's a function of how big the growth is inside the organ. N as in Norman, refers to nodes, lymph nodes. Has it gotten into the nearby or further lymph nodes? And you might see nomenclature N1, N2, N3, depending on where it is, nearby or far away. And then M refers to metastatic disease or spread beyond nodes, whether it be to bones or the liver or the lungs. And so that's typically how we stage it. So the ideal patient, for example, who we may touch on this later in this podcast, if they opt for a radical prostatectomy, and it comes back as T2, which is organ confined prostate cancer, and it's N0, M0, there's a very high chance we've hopefully cured those men.
It's a surgical cure at that point.
At that point, exactly.
One of the scary things, I think, about, many cancers just in general, at the beginning, when you want to actually make the diagnosis and start treatment early, no symptoms. I mean, there's very few symptoms with prostate cancer. Are there anything from a symptomatic perspective? Is there anything that a patient, a man, would be sort of concerned because you're having some sort of a symptom? Is there anything that people should be looking for?
Yeah, so that's a good question, right? So there's basically two diseases of the prostate that affect the aging male. One is prostate cancer, which we're talking about, but the other is what we call BPH, or a benign prostatic hyperplasia, or an enlarged prostate, or a big prostate. As we get older, that's a function of aging and exposure to testosterone and time. And that's benign, right? And so it's interesting. So in terms of the initial diagnosis, when you may want to suspect prostate cancer, it's exactly like we described. It's a man who's well, who comes in for a checkup, who probably has zero symptoms. And we pick it up on all of the things we just touched on: blood work, rectal exam, vigilance around family history, whatever that might look like. It's interesting, if somebody actually says they've had progressive urinary symptoms with a slow flow, I might actually worry a little less. And if I'm staring at a PSA that's borderline, and one man has no symptoms and another man says, listen, it's slow to void, I can't put out a fire anymore, I get up a little more at night, you could use that as a surrogate, at least clinically, before you do any other testing, to say, his prostate's probably bigger than the other guy. And if it's bigger, he's likely just producing more PSA based on size. And I may be able to explain away a higher PSA just based on that. And so that's the subtle distinction, right? That early on, symptoms may actually be a good thing, right? I mean, we still would biopsy somebody if we were worried and the PSA was significantly elevated. But if I was equivocating and I knew the patient's prostate was big and the PSA was borderline, and we're having this conversation about what we may do, what we may not want to do, that might actually tease me to follow, sway me to follow a little bit longer. Prostate cancer at the symptom stage is usually related to progression of disease. So you can get certainly urinary symptoms, but it's usually when it's significantly bigger, there's growth, there's obstruction, loss of appetite, if it gets into the bone, bony pain, failure to thrive. I mean, these are all of the signs of advanced disease. And so, obviously from our perspective as the gatekeepers on the diagnostic side, we would like to find every man before they ever get to that point. And, and as we will presumably talk about in a minute, that's the hard piece. And for a lot of men to stomach, because they're perfectly fine. And then you're making judgments that this will become a problem. And then therapy then comes with consequences that create symptoms that we then need to manage. And that's sort of the, in many ways, that's the hard part, and the part that really needs a lot more time to walk our patients through.
Yeah, and just before we get into a bit more on treatment, you mentioned testosterone as that hormone that tends to grow prostate over years and years. And I get often questions about, gosh, if I'm taking testosterone because my natural testosterone is actually falling away, I'm feeling very tired, I'm losing muscle mass, and I want to actually take exogenous testosterone, is that a higher risk for basically causing cancer? Is that a risk for cancer?
No, there doesn't appear to be any good evidence to suggest that. When we go through life and we see our primary care and we get assessed, we can't isolate it from body part to body part, right? I mean, everything matters in order to manage our patients in a way that's thoughtful and productive. So I think where you have to have a conversation is in that situation where you might contemplate it, and there are clearly elements that are risk factors in that individual's life, right? And it may be a horrendous family history, and that may be a scenario where you might say up front, let's just tease it out a little bit. Let's maybe get an upfront MRI or whatever that might look like. But by and large, the idea that it would turn on something, there is no advice to that, or no great evidence to that.
Yeah. And I think one of the other things that the benefit of Medcan is sort of longitudinal screening as well.
Yeah.
And so maybe a word about the absolute value of the PSA versus the trend, like that change in the number over time. And how do you tease those two things apart?
For this Medcan client, it was the trend that set off alarm bells for Dr. Singal.
In December, I got a call from Dr. Singal, and he said there's a 7-millimeter lesion on the left side of your prostate. And once again, he said, if you wish, we can just monitor it. Or the next step, if you want to be more proactive on your health plan, would be to get a biopsy. And of course, I said, let's go. And then May 8th was the inevitable day. I got the phone call from the doctor, and he said, you have significant disease. And the thing with prostate cancer is you don't want it to spread.
So there's a gestalt to all of this, isn't there? And I think that's probably the first answer. I think trends do matter. I think having a baseline helps. And so obviously at Medcan, we do that. Having a baseline roughly at age 40, 45, I think is very important for everybody. If that baseline is negligible, not just normal, but negligible, less than 1, which about 90% of people tend to have, it's not unreasonable to get a repeat PSA in 5 years or 3 years or 5 years. Like I'm talking broadly. We tend to do it a little more often at Medcan.
For this client in particular, the Medcan way was the difference in catching his prostate cancer before it could have been too late.
So my sister, the doctor, I finally got the full clinical report from Dr. Singal, and she reviewed it, and it was like 33 pages long. And she said, Doug, you really got lucky. And this is what Medcan is so good at. Because, if you were going to a regular GP, when you're under 59, the range for PSA is 3.5. And so a GP might not have wanted to stress the system by sending you in for a PSA test at Life Labs because you're still inside the range. And then when you turn to 60, your range goes to 4.5. So, I said, Dr. Wartzman at Medcan, I've said to him, you flew the flag on the play, to get me, into the process. I might have been just here talking to you today, not knowing that I had prostate cancer because it wasn't symptomatic. I had no evidence of anything going on.
And if you can get to age 60 with a PSA of less than 1 and you've documented stability, your risk of having prostate cancer in any meaningful way moving forward, while not zero, is pretty close to zero, right? And we can counsel some of those men accordingly. There was a patient, one of the patients here that we've heard from is a perfect example of how you have to be thoughtful, bring the patient into the conversation around what are we hoping to achieve.
Depending on their situation, some men opt for surgery while others opt for radiation, but it's always important to have an in-depth chat with your healthcare provider as you make that decision. Here's how Michael chose to opt for surgery.
Really the key thing is to know that the treatment worked at the end of the process. That was really the determining factor to go for surgery, because having removed the prostate, it could be sent out for examination. They could test all around the outside. Some of the other treatment options wouldn't necessarily give you quite that assurance. And to be fair, I was with Dr. Singal, and he is a surgeon. That's what he does, and he was doing, 2, 3, 4, 5 of these a week at the time. So you kind of know that, if he thinks that's the best option, and he really didn't pressure me one way or another, but it was kind of clear that that's sort of what he thought would be best. And then after that, Dr. Singal likes to keep in touch with his patients. So I basically had a visit with him once a year, get some blood work done. He obviously got the results of my annual physical from Medcan, the blood work from that. And I guess we did that really till about last year when he said, enough time's passed, we probably don't need to do this anymore. I went back to work after 3 weeks. Within 2 months of surgery, I'd been traveling and playing golf and so on. Not well. That was a bit of a mess, but,
Our other Medcan client also opted for surgery.
Quickly became clear to my wife and I that the smart play, because I was a young guy, I remember talking to, a doctor at Medcan, and he said, listen, you're going to live to be 90 unless this gets you, because you're really, really healthy, absent prostate cancer. It's something that you just got to deal with. So I decided to do the surgery.
In that situation, there was some days, you look at it, a guy who's in his late 50s, early 60s, PSA is ostensibly normal by age criteria. And what happened in that situation, you look at it a year before, 2 years before, 3 years before, it wasn't actually a big jump, but there was a little bit of a trend. Doubling times of 2 to 3 years worry me. And so there was a little bit of, he was kind of on pace for that. But the conversation still was, you might have something, you might not. But if you did, you're of an age where you're otherwise going to live 25 years or 30 years. And if we found something, and if what we found was real, we would want to pick it up, right? So that was up front, that conversation that I had with him, and then we, in that case, actually, Peter, found Gleason 8, a very significant prostate cancer. It then becomes, holy crap, I'm glad we found it, right? And it's amazing. I've been doing this almost 30 years, that two-way discussion, right? We talk about shared decision-making, but patients are only going to be able to really lean into that if we can actually frame it for them in a way that makes sense. And the other thing, of course, is our Medcan patients, by and large, are highly engaged, educated, sophisticated, very much attuned with their health. And so you can have these nuanced discussions in a way that's very rich. Ultimately, on the treatment side, and we'll tease out things, but the importance of a motivated patient, even on the recovery side, to get better, it's so important. And, our Medcan patients are very motivated, right? You give them a challenge and it's like, well, how do I exceed that, right?
This Medcanner is a prime example of that motivation to be proactive when it comes to wellness.
Somewhere in late June, I decided to start a step streak that I committed myself to maintaining even during my surgery and after my surgery. So I went for the surgery on August 29th. It was a very interesting experience. It was something that I'd been doing on and off. My youngest daughter had challenged me, and I had just inadvertently broken a streak of, I think it was 81 days in a row. And I thought, you know what, I'm just going to start the streak again, and I'm not going to stop. I'm not going to break this streak. I'm going to do it right through my surgery, right through my recovery, right through into the next year. So, walking, if you get the distance in, I learned that, is 80% as good as running the same distance. So if you walk 1.25 times what you used to run, you're going to be better off. And it's sort of something that I could control, because I couldn't control a lot of this, but I could control that. And the key was that I made the decision that I would do it even through my surgical experience.
I saw him on the ward here the evening of surgery, and he looked great. And he said, I'm not gonna burn my streak today, right? And he just had an anesthetic 3 hours earlier.
It's a 4-hour plus procedure. I go up into the post-op ward, up on the 6th, the 7th or 8th floor at Michael Garron. And as soon as my wife gets there, and I've got forgive the listeners, I've got a catheter in there, and I got a IV in my hospital gown, and I said to my wife, I got to start getting my steps, because it's like 3:00 and I've only got 1,000 steps. So I start walking circles around the post-op ward, and it got to a point where it became kind of comical, because there were some stations where there were attendants there that were like cheering me on. And there's this one other guy who was an older gentleman who was quite concerned, because I just had major surgery, and I'm walking all the way around.
We have a big circuit here at the ward. And so he did it. I made rounds the next morning. He said, I got my steps in, and he's the one. And I tell everybody since, right? I now know it is 330 steps to do a loop around our ward, on the surgical ward here. And I got that information from him, right? And so, you can do the math. He maybe did 1,000 steps before he came in that morning, which in many ways seems almost impossible to me, as much as I love to see my patients up the night of surgery.
I was able to determine that one complete lap of the post-op ward is 331 steps. And so you need to do roughly 30 laps to get your 10,000 steps. So I did it. And to this day, Dr. Singal now has told this story to many men that go through surgery for prostate cancer.
Pretty special. And part of his recovery has been, it's very little what I did. It's all because of what he has done.
Yeah. And again, probably not atypical for our population. I know our physicians all really enjoy working with our patients because they are motivated, they're very engaged. So really excellent and really two-way benefit there for sure.
And both of our Medcan clients today saw some amazing results from their surgery. Here's Michael's experience.
Dr. Singal likes to keep in touch with his patients, so I basically had a visit with him once a year, get some blood work done. He obviously got the results of my annual physical from Medcan, the blood work from that. And I guess we did that really till about last year when he said, like, enough time's passed, we probably don't need to do this anymore. I went back to work after 3 weeks. Within 2 months of surgery, I'd, been traveling and playing golf and so on. Not well. I was a bit of a mess, but, I'd just like to say thanks one more time to Dr. Singal, leading up to it, surgery, and afterwards. And couldn't have a better doctor.
And here's our second Medcan client.
The pathology came back, and the good news was that what they thought might have been a Gleason 8 was only a Gleason 7, so it was still serious, significant disease, but it wasn't as bad. But also they got all the margins were clear, all the lymph nodes were clear, so everything around there was clear. And then he said, you need to come back to me in 90 days. We'll do another PSA test. So I went in November, and then in December, the PSA levels were indiscernible, like nothing. And he said, well, we're going to do it again. You're going to come back and see me in end of March. Did it again in April, PSA levels indiscernible. So now he said, come back in 6 months. I'll see you in kind of November. So that's basically where we are right now in terms of my prostate cancer journey. But, Dr. Singal said, I'm going to be tracking you for 10 years, so you're not getting out of my sight, but your recovery's been very, very good. And I see him at the gym. We go to the same gym. So I see Dr. Singal at the gym from time to time. So it's always funny. Yeah, a little visit.
Well, I guess to leave on a positive note then, it really underscores the importance of screening. And is there anything from a lifestyle perspective that men can do to reduce their risk of having prostate cancer?
Yeah, unfortunately, there's nothing great. None of the data has ever shown if you do this, you'll prevent prostate cancer or you'll reduce your risk by X. Keep moving, get checked, be aware. Those are probably the things that matter. From an enlarged prostate symptom perspective, certainly on that side, maybe just to close things, that there's a lot people can do if you have some symptoms, and instead of just lazily tossing medications at someone or saying, we can fix it with a procedure, there are things people can do if they have urinary symptoms related to benign outlet obstruction, caffeine mitigation, alcohol mitigation, optimizing bowel movements, increasing your fiber, reducing your fluid intake in the evening, mitigating stress. All of those things are constant things that we would, and you've seen me write those in a variety of notes over the years, Peter. So those are all common things we do.
And here's some advice from our two Medcanners who went through this entire process themselves.
It's very likely that I could have, if I'd been not at Medcan or not had the care, that I might have been just here talking to you today, not knowing that I had prostate cancer, because it wasn't symptomatic. I had no evidence of anything going on except for my PSA markers were going up. So another thing I would really encourage every single man, to get yearly PSAs. It's so easy to do. It's just a blood test at the Life Labs around the corner. And, insist upon it with your GP if he or she isn't asking you for it, I would say.
If you're diagnosed with it, it isn't the end of the world. There's lots of types of cancer where if they tell you you have it, you need to be really worried. The figures that I saw at the time when I looked at it was, probably 70% of people that get it don't need to do anything except monitor it. At least if, depending on how old they are when they get it and how much it's developed at the time it's caught. That's great if you fall into that group, and I didn't. But if you don't, then figure out what treatment option seems best to you and go for it.
Well, this has been such an inspiring conversation. Big thanks to our patients who are willing to share their story with us, and certainly to Dr. Singal for taking his time today.
Thank you so much for inviting me, Peter. And it's just it's an honor to be part of the journey.
That was Medcan's Chief Medical Officer, Dr. Peter Nord, in conversation with Medcan's Director of Urology and Michael Garron Hospital Chief of Surgery, Dr. Rajiv Singal. This episode also features stories from two Medcanners, including Michael Sharp. So we just want to say a huge thank you to these clients for sharing their journeys with us. To learn more about prostate cancer screening and your risk, visit our website at medcan.com. Follow Medcan on X, Instagram, and subscribe to us on YouTube at Medcan Live Well. Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com. Eat Move Think is produced by Ghost Bureau. I'm Jasmine Ratch, managing producer. Social media and strategy support is from Chantel Gertin, Andrew Imex, and Elaine Genet. Executive producer is Christopher Shulgin. And we will be back soon with another episode examining the latest in health and wellness. This podcast episode is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with any specific information highlighted. Any third-party links are not endorsed by Medcan.